I'd like to thank Doctors Lee and Chakrabarty for the invitation to speak at this year's ACG Eastern Regional course and for the opportunity to speak on the important topic of obesity. The AMA has defined obesity as a disease, and the World Health Organization has classified obesity as a global epidemic. I believe gastroenterologists are uniquely positioned to help this struggling patient population. And we'll begin this talk with a brief overview of obesity and traditional treatment options, then spend the rest of our time focusing on endoscopic management strategies. So what is obesity? Well, here is an enhanced scanning electron microscopy image of adipose tissue from a patient with obesity. And here we see adipocytes, and around those adipocytes are activated macrophages. So obesity really is a state of chronic inflammation of the adipose tissue. Here we have another way to illustrate this. On the left, we have what adipose tissue would look like from a healthy subject, and you can see it has M2 macrophages, and this tissue would secrete innocuous cytokines such as IL-10, IL-4, and IL-13. However, on the right, we have an example of adipose tissue from a subject with obesity. And you can see this is chronically inflamed with B cells, mast cells, and metabolically activated macrophages. And this tissue secretes substances such as adiponectin, resistant, and toxic cytokines, including TNF-alpha, IL-6, and IL-1 beta. And these substances are then released into the systemic circulation and contribute to those comorbidities we see associated with obesity, including vascular disease, NAFLD, and type 2 diabetes. Body mass index is weight in kilograms divided by height in meters squared. And although BMI does not define obesity, it is used to classify obesity to gauge severity of illness and determine who is eligible for what therapies. Here we see obesity class 1 is a BMI of 30 to 34.9, class 2 is 35 to 39.9, and class 3 is greater than 40. Patients with a BMI of greater than 35 with a comorbid illness or greater than 40 are eligible for surgery. All patients are eligible for and should be encouraged to pursue diet and lifestyle modification, and there's several different diet plans out there. Unfortunately, they lead to only about a 3% total weight loss, and only 3 to 5% of dieters can maintain that weight loss up to 5 years. So this is certainly a means of prevention. However, once someone develops obesity, it does have limited impact. Nevertheless, it's extremely important for them to correct these things because they're critical to the success of medications, endoscopic therapies, and surgery. Surgery is very effective, and there's many types to choose from, including those that focus primarily on the stomach, such as the sleeve gastrectomy and adjustable gastric band, and those that incorporate an element of small bowel bypass, such as the Roux-en-Y gastric bypass, which has a small gastric pouch connected to a roux limb that bypasses the foregut, and various longer limb bypasses. And we know that the risks and benefits vary for these procedures, but the small bowel procedures do have a more direct metabolic impact. Moving on to endoscopic bariatric and metabolic therapies, or EBMTs, and these procedures can be broadly classified into two groups. Gastric procedures, including space-occupying devices such as the Intragastric Balloons, gastric remodeling, including suturing and plication, aspiration therapy, and similar procedures. And these primarily affect weight loss, and they may have secondary effects on metabolic comorbidities. And then your small bowel devices, including your liners, duodenal and mucosal resurfacing, and anastomotic technologies. And these have strong direct metabolic effects on conditions such as diabetes, and they may also be associated with weight loss as well. And many of these devices are FDA approved now, you see on the left, and we'll be focusing on these first. Regarding mechanisms of action, they're not entirely clear for these devices. However, we do think that the space-occupying devices work via inducing an element of gastroparesis, delaying gastric emptying, which can suppress ghrelin. And it's also possible that some of the suturing devices do that, but the suturing devices may also speed up gastric emptying and lead to more of a hindgut effect, spiking GLP-1. So we're learning more about these in an effort to help tailor these procedures with an eye towards personalized therapy. However, that's a work in progress. And we'll start with intragastric balloons. There are several balloons available around the world, including gas-filled balloons and fluid-filled balloons, and balloons that you can kind of adjust the volume of intermittently as needed, and some balloons that don't require an endoscope replacement or removal. So in the United States, we have primarily the gas and the fluid-filled balloons. And here are the two intragastric balloons currently approved in the United States and commercially available, the fluid-filled balloon and gas-filled balloon. And the gas-filled balloon you may stage in multiple here. The indications for these include obesity class 1 with at least one obesity-related comorbidity or obesity class 2, contraindications, prior gastric surgery of any type, large hiatal hernia, among some others. Now, other balloons have gone through FDA trials and looks like they will be approved, including adjustable intragastric balloons and the procedureless balloon systems. And there's also another device that is approved, the transpyloric shuttle, but not commercially available. Here's a meta-analysis of 17 studies using a fluid-filled balloon. They included over 1,600 subjects. And you can see the excess weight loss at 12 months was 25 and the total weight loss 11.27 at that time. And you can see this was consistent really across all BMI categories, even in the higher categories, so it's quite interesting. Here's another meta-analysis including 10 RCTs and 30 observational studies with over 5,600 patients. And this focused on obesity-related comorbidities. And you can see here that the overall decrease in HbA1c was 0.6%, but in those who are pre-diabetic or worse, they had a 1.1% reduction in A1c. There was also improvement in waist circumference, fasting blood glucose, hypertension, LFTs, and dyslipidemia. The SAE rate for this study was 1.3%, including 5 gastric perforations, and a mortality rate of 0.04%. Again, emphasizing you should not use these in patients with any history of gastric surgery. Continuing with adverse events, we have an AGA technical review that looked at 7 RCTs and over 1,000 subjects, and the quality of evidence was fair here. And you can see overall there was a 5.6% SAE rate with perforation and hemorrhage and various complications relatively low in incidence, and early removal about 9.4%. And in general, the gas-filled balloons fared a little bit better from a tolerance standpoint. What about long-term results following balloon removal? So again, most of these balloons have to be removed at 6 months. So this is a prospective open-label study looking at 500 patients, and they had 5-year follow-up. 26 were excluded due to protocol violations, and then 17% did not make inclusion criteria of 20% excess weight loss at balloon removal. So we're really starting here with 395 patients, and 100% of them had at least 20% excess weight loss. And you can see over 5 years, that drops down to about 20% of patients maintaining that weight loss. So not terribly durable. We have a percent total weight loss in the low single digits there. But good short-term results, and really we have to think about using medications or other means to maintain that weight loss. Moving on to gastric remodeling, and here we have our original patent from the early 2000s, which included various methods, including closing gastric fistula, revision of the gastro-jejunal anastomosis and pouch, and various primary obesity therapy concepts. And we'll start with revision of the gastro-jejunal anastomosis. The RESTORE trial was a randomized sham-controlled trial with a 6-month crossover comparing transoral outlet reduction, or the TOR procedure, using a suction-based superficial suturing device, not full thickness like our current devices. And it was a 2-to-1 randomization, as you can see here, with intent to treat analysis. And the treatment group and sham group had similar weight loss for the first 6 weeks, and then their diets were liberalized, and the treatment group kept their weight off, but the sham group put their weight back on, and this was statistically significant. They then crossed over at 6 months. The procedure has since undergone several refinements, including use of a full thickness suturing device and a purse string suture pattern, which is completely circumferential, and then it's sized over a balloon instead of using interrupted sutures as was done in the RCT. And you can see we now have 5-year data using this new pattern with over 331 patients, and there's an 8.8% total weight loss at that time, with 62% of patients maintaining at least 5% total weight loss. And the most recent version also involves removal of the mucosa around the outlet, and we're currently collecting data on that. Gastric remodeling is also used as primary therapy and either has tried to replicate the vertical banded gastroplasty or gastric imbrication procedures. And we'll spend most of our time discussing the imbrications as this is most popular currently. The TRIM trial was first to explore endoscopic gastric imbrication, working on the greater curvature with a pattern very similar to the original ESGs. And we worked together with the Cleveland Clinic on this first-in-man study, which included 18 subjects, and we achieved a 27.7% excess weight loss and 30% excess weight loss for patients in lower BMI categories. There's also improvement in other metrics here, and you can see the final appearance very similar to an ESG. Unfortunately, few of these plications were intact at 1 year, and despite improvement in various subjective measures, this was not successfully commercialized. Then about 4 years later, in 2012, Rob Hawes and I had the pleasure of doing first-in-man ESGs using a full-thickness suturing device. And we did this in India, and after those first 4 patients, we expanded this to 126 patients in India, Panama, and the Dominican Republic. And you can see here we had an average BMI drop of 36.2 down to 29.8, and more impressively here, nearly a 20% total weight loss. Reem Shariah subsequently published a prospective series of 91 patients with 2-year weight loss outcomes, and you can see here she had a 20.9% total weight loss at 24 months and a 1.1% SAE rate. And uniquely here, she also published comorbidity resolution. You can see here there was a 1% drop in A1C for pre-diabetics and diabetics, as well as improvements in blood pressure, triglycerides, and ALT. She followed this up with a 5-year retrospective single-center study looking at 216 patients. And you can see here that 68 were eligible for 5-year follow-up, and there was an 82% follow-up rate there. And they achieved a 15.9% total weight loss, with 90% maintaining 5% total weight loss and 61% maintaining 10% total weight loss, and 27% being started on pharmacotherapy at some point after ESG. So very nice results, again, with a 1.3% adverse event rate. Until this point, the majority of studies had utilized a double triangle pattern. However, there are several other patterns that are currently being employed, and the most common right now is probably the U-stitch, seen here, where you start on the anterior surface, run the suture along the greater curvature to the posterior surface, then move proximally, and then return along the greater curvature to the anterior surface. And that proximal movement helps to shorten the stomach. Some sites will do reinforcement and others do not. I prefer an interrupted reinforcing suture or an I-stitch. So we do UI, and repeat until we reach that proximal gastric body. And the average number of sutures does vary, somewhere between 3 and 10 depending on centers. Utilizing this U-stitch pattern, we participated in a multi-center international study, which included 7 centers of varying experience, many of which were very early in their learning curve, having done few procedures. And an average of 4 to 6 sutures was utilized. And you can see here the percent total weight loss was 15% at 12 months, and this was uniform across centers, showing good generalizability, with all centers having at least 10% total weight loss. Also uniquely here, we found predictors of success, including age less than 41, male sex, and higher BMI, which was a bit of a surprise. You can see patients that were overweight did not lose as much weight as those with obesity class 3. So another nice finding there, and the SAE rate was 1.03% in keeping with prior studies. Al-Khattani also utilized this U-stitch pattern in a prospective observational study of 1,000 patients, and he found a similar efficacy of 15% roughly at 12 and 18 months, with an SAE rate of 2%, And what was interesting here is he was able to revise these procedures endoscopically and actually completely reverse them by cutting out sutures. So that was a unique finding. And he also found that the weight loss trend was very similar to his other patients with adjustable gastric bands. And pulling it all together, we have a meta-analysis which included 8 studies with over 1,700 patients. And you can see here again a 16.5% total weight loss with a 2.2% adverse event rate. Moving from suturing to gastric plication, here you can see we acquire tissue and pull it into a tissue grasper, and then a hollow needle is passed through that tissue, as you see here, hollow needle. And then through the hollow needle, a tissue anchor is deployed distally, and then the device is opened up again and another one placed proximally. And what's different here is instead of mucosa to mucosa, which is what we get mostly with suturing, we have serosa to serosa opposition, which is potentially more durable. And that's what it looks like 1 year later. Unlike ESG, the original version of this procedure focused on the fundus, and this was studied in a randomized controlled trial called the Enteral trial. And you can see there's a 2-to-1 randomization set up here. And unfortunately, it did not hit its endpoints, with the treatment group having about a 5% total weight loss and the sham having about a 1.4% total weight loss. Subsequently, this procedure was modified to focus on the gastric body instead of the fundus, and this is referred to as distal pose or pose 2.0. And you can see at 6 months there's a 15% total weight loss, with 100% achieving 5% total weight loss and 80% achieving 25% excess weight loss. And these procedures do quite well at a year, approaching 20% total weight loss. Here's another study from Spain looking at this distal pose pattern, and they included 75 patients and had nearly an 18% total weight loss at 12 months. Interestingly, they also found that the higher the initial BMI was, the more total weight loss there was, ranging from 15.2 to 20.3%. Shifting gears to aspiration therapy, and this is very much like a PEG tube. It has a skin port here that connects to a device that allows you to lavage the stomach 20 minutes after a meal, and there's a long fenestrated drain that resides in the fundus. And this was studied as part of the Pathway Trial, which was the pivotal US trial. And 111 patients underwent therapy with 60 undergoing lifestyle control, and there was a BMI range of 35 to 55 here. So it was successfully placed in 111 of 113 patients, and all but 3 subjects were discharged home the same day, all for non-medical reasons. The study had co-primary endpoints, the first being mean percent excess weight loss, and this required at least a 10% margin over the control group. And you can see in the intent to treat analysis, the treatment group was over 30% and the control group was under 10%, so that met its endpoint, even more impressive in the completers. Then the other endpoint was response rate, which they wanted at least 50% of the treatment group to have at least 25% excess weight loss. And again, this was met as well, with over 50% meeting that in the treatment group, and the control group falling far short. So this did meet both endpoints and was FDA approved, and it's commercially available. Another feature of the device is that the longer it is used, the more weight comes off. So you don't have that plateau. And you can see as part of the 4-year follow-up study, patients that continue to use the device achieved nearly a 19% total weight loss at that 4-year mark. Regarding adverse events, there's no sign of electrolyte issues or eating disorders. Persistent fistula is the one thing to look out for, and there's 12.5% of patients that required endoscopic intervention for a fistula and another 2.1% that required surgery, so it's important to act early, especially if there's been a long dwell time. Moving on to small bowel devices. Now, while most of what we've talked about so far has been FDA approved and clinically available, these devices are all currently under investigation, most in their pivotal trials in the United States. And most of these devices focus primarily on diabetes, which we know is also a pandemic affecting over 387 million people worldwide. In order to understand the mechanism of action for many of these devices, it's important to understand the incretin effect. If you give a subject a set amount of glucose intravenously, they'll produce a set amount of insulin seen by the red line. If you give them the same amount of glucose orally, they produce much more insulin. And this is thought to be a normal incretin effect. and is due to the release of gut hormones from enteral endocrine cells in response to food, short-chain fatty acids, or bile. In type 2 diabetes, this incretin effect is substantially blunted, and surgery as well as endoscopic procedures seek to reconstitute that normal incretin effect in an effort to reduce insulin resistance, treat type 2 diabetes, and encourage weight loss. Here we see GLP-1, which is a classic incretin, and it can do all sorts of things, including slow gastric emptying, cross the blood-brain barrier to give a sense of satiety, as well as improve insulin secretion. Another important concept here is Foregut and Hindgut hypotheses. And you can see the white dots represent enteral endocrine cells that produce incretins. They get denser the more distal you go, even into the colon. And the black dots represent anti-incretins, which is a more generalized concept right now. And the theory is that Roux-en-Y gastric bypass silences anti-incretins, which would protect against hypoglycemia technically, and enhance incretin production. So those are the two mechanisms. Here we have a study from Francesco Rubino's group in Italy that randomized 60 subjects to receive medical therapy, gastric bypass, or biliopancreatic diversion. These were all diabetics with obesity. And their primary outcome was success, defined as an HbA1c of less than 6.5% at 2 years. None of the patients in the medical therapy group achieved success, where 75% of the gastric bypass did and 95% of the biliopancreatic diversion did, showing the importance of these theories. The duodenal-jejunal bypass liner is thought to work by both of these mechanisms, sheltering the duodenum from having contact with food and dumping bile and food into the distal bowel without mixing. And here we have a meta-analysis looking at the DJBL in a patient population that had type 2 diabetes and obesity. And you can see how it's placed here using endoscopy to position a wire into the duodenum, and then the device is guided under fluoroscopy into position there. And they had a 1.3% reduction in HbA1c at 1 year. Additionally, there was a 19% total weight loss. So you can't have weight loss with these procedures. With the initial pivotal study, there was some issues with hepatic abscesses, so the protocol has been modified and they are again now enrolling patients. Next, we have duodenal mucosal resurfacing, or DMR, and you can see the device being placed over a wire under fluoroscopic guidance. And then basically this balloon is filled with fluid, and it presses these channels up against the mucosa, and then the mucosa is aspirated into the channels, and the needle is advanced into the submucosal space to create a fluid cushion. The water in the balloon is then heated to ablate the mucosa. And this focuses primarily on the Foregut hypothesis, ablating this mucosa, trying to reset the cells. The first in-human study was a single-center study performed in Santiago, Chile, single-arm open label. You can see that the BMI wasn't terribly high at 30.9, but they did have very poorly controlled diabetes with an HbA1c of 9.5. Overall, the A1C dropped by 1.2% at 6 months, and this was after mucosal healing was confirmed on biopsy. And if you looked at the group of patients whose background medications were stable, they had a 1.8% reduction in A1C. They followed this up with a multi-center open label study, including several sites in Europe, and the patients had similar baseline characteristics with a BMI of 31.6 and HbA1c of 8.6. Outcomes very similar, improvement in HbA1c, HOMA-IR, liver tests. What was new here, though, was the MR hepatic fat fraction found improvement, 30% lowering of relative fat and 6% reduction in absolute fat. So very interesting findings there. And finally, we have anastomotic technologies. And you can see here this requires placement of endoscope from above, just beyond ligament of Triton, from below up above the IC valve. And then once these are in position, magnets are placed down the channels, and then they are coupled under fluoroscopic guidance. And this results in a side-to-side anastomosis. So that means that the native path is still open, so there's no long blind limb, and there's also a shortcut so that food or bile can enter the distal bowel very quickly. And this is thought to mitigate against complications, yet still have a treatment effect. This focuses only on hindgut mechanisms. The duodenum is not affected here at all, so there's no foregut effect. Here are the results of a 10-patient pilot study performed with laparoscopic supervision. And you can see 3 were pre-diabetic, 4 diabetic, and of the diabetics, the A1C improved from 7.8 down to 6 at 36 months, and the rest improved from 6.1 down to 5.2 at 36 months. So a very nice metabolic effect there. And additionally, there was a 14% total weight loss. This slide highlights the rather full spectrum of therapy we can now offer our patients, with pharmacotherapy yielding a roughly 5 to 8% total weight loss, balloons at roughly 10% total weight loss, suturing and plication at 15 to 20%, aspiration therapy for those higher BMIs up to 20% total weight loss, and sleeve gastrectomy and gastric bypass at the top there. In conclusion, endoscopic, bariatric, and metabolic therapies are proving to be effective and have an important role in the treatment of obesity. These therapies may also hold promise in the treatment of type 2 diabetes and across the spectrum of fatty liver disease. And I believe combination therapies, including combinations with devices and medications, or devices with different mechanisms of action, such as gastric and small bowel devices, as well as personalized treatment programs, are now the keys to future success. Thank you for your attention.